If your doctor only orders LDL, you might be missing the most important number for heart risk. Meet ApoB, the particle count that tells you how many cholesterol-carrying bullets are circulating through your arteries right now. LDL-C measures the cholesterol inside the particles. ApoB tells you how many particles there are. Heart disease is still the #1 killer, and here's the uncomfortable truth. Plenty of people suffer heart attacks with normal LDL on their last lab. That happens because LDL can look fine while the number of atherogenic particles is still high, and that particle count is what ApoB captures. Picture your bloodstream as a harbor. LDL-C is the total cargo weight moving through the channel. ApoB is the number of ships trying to dock. More ships means more chances to bump into the pier, your artery wall. Or, if you like a spicier analogy, LDL is gunpowder, ApoB is bullets in flight. You can keep the same amount of gunpowder in fewer big bullets or lots of small ones. Only one of those scenarios fills the air with risk. ApoB counts the bullets. Here's the short course in the biology. Each atherogenic lipoprotein, VLDL, IDL, LDL, and even lipoprotein, carries exactly one ApoB 100 on its surface. Count the ApoB molecules per deciliter, and you've essentially counted the total number of bad particles capable of burrowing into artery walls and starting plaque. Why does LDL alone miss people? Because LDL-C is usually calculated and assumes average particle size and normal triglycerides. In insulin resistance, high triglycerides, or metabolic syndrome, your body often churns out many small, cholesterol-depleted LDL particles, so LDL-C looks meh, while ApoB lights up like a dashboard warning. Same story for patients already on statins. LDL-C can drop beautifully, but the residual risk, what's left after treatment, tracks more tightly with particle number. If ApoB stays elevated, so does your risk, even when the LDL line on your app is green. The research is remarkably consistent when LDL and ApoB disagree, a situation called discordance. Event risk follows ApoB, not LDL. Across large cohorts and modern analyses, ApoB outperforms LDL-C, and often non-HDL-C, for predicting who actually has heart attacks and strokes, especially in people on therapy or with metabolic issues. Let's apply this to real people you know. Person A and Person B both have LDL-C of 100. Person A has low ApoB, fewer particles carrying the cholesterol. Person B has high ApoB, many more particles. Same cargo weight, very different number of ships, very different risk. Who's most likely to be missed if we don't check ApoB? Anyone with insulin resistance, prediabetes, type 2 diabetes, or higher triglycerides. People with obesity or metabolic syndrome. Patients whose LDL looks good on statins but who still have a strong family history, a positive calcium score, or elevated LP. These are the normal LDL, hidden risk cases ApoB was built to find. What do major societies say right now? Europe and Canada have already moved. ApoB is recommended as a target, with explicit goals by risk tier. US guidelines remain LDL first, but expert statements and reviews increasingly emphasize ApoB as the sharper lens, so the practice is shifting even if every guideline hasn't played catch up yet. Let's talk numbers in a way that's useful and sane. Most labs consider ApoB under about 90 mg per deciliter desirable, with 90 to 99 above desirable, 100 to 119 borderline high, and 120 plus high. European guideline style targets for people at higher risk land around 65 to 80 mg per deciliter, and many prevention-focused clinicians would love to see long-term ApoB below roughly 70 in high-risk or very risk-averse patients. Your target should be a conversation with your clinician, not a YouTube dare. So how do you get an ApoB test? Ask your clinician directly for ApoB, or an advanced lipid panel that includes ApoB, This isn't an exotic send-out test. Big labs run it routinely. Fasting usually isn't required for ApoB, but clinics may still ask you to fast if they're drawing a standard lipid panel at the same time. When your results come back, read context, not just colors. ApoB high with normal LDL-C means you're likely carrying too many particles, often a metabolic pattern of many small LDLs. ApoB low with higher LDL-C is rarer but possible. It reflects fewer, larger particles and often less risk than LDL alone suggests. Again, when numbers disagree, risk follows ApoB. What lowers ApoB over time? First lever, improve insulin sensitivity and reduce liver VLDL production. Weight loss, even modest, does both, especially if you carry weight centrally. Second lever, eat a Mediterranean-style pattern, plants, legumes, whole grains, nuts, fish, and extra virgin olive oil, less refined carb and less ultra-processed food. That pattern consistently improves cardiometabolic risk and tilts lipids in the right direction. Cut the refined carbs and sugary drinks that spike triglycerides and drive particle production. Lift and move. Aerobic work and some resistance training won't tank ApoB by themselves, but they improve the metabolic backdrop that keeps ApoB down. Sleep in a regular window and manage stress. Your liver listens to your hormones. Medications are powerful tools when lifestyle levers aren't enough or your risk is high. Statins remain first line and lower both LDL-C and ApoB along with events. Ezetimibe adds another notch. PCSK9 inhibitors or inclisiran can drive particle numbers very low in high-risk cases, and newer agents like bempedoic acid can help the statin intolerant. The Throclin, even when you're on meds, residual risk maps better to ApoB than LDL-C, which is why clinicians increasingly watch ApoB to know if therapy is finished. Let's build your ApoB action plan in 3 steps. Step 1. Pull your last labs and check whether ApoB is listed. If not, add it to your next draw. If LP hasn't been checked at least once in your life, ask for that too. It piggybacks on ApoB and adds independent risk. Step 2. Give yourself 12 weeks on a simple metabolic reset. Mediterranean-style eating with fewer refined carbs, 150 to 300 minutes of cardio plus 2 strength days, regular sleep, and a modest calorie deficit if you need weight loss. Retest ApoB after the block to see how your particle count responds. Step 3. Discuss targets with your clinician. If your ApoB remains high, decide together whether to adjust diet composition further or add medication to get particle number into a range that fits your risk and your goals. ApoB transforms guesswork into a scoreboard. You can actually see whether your protocol is reducing the bullets in circulation. Before we close, a few quick myths to retire. My LDL is fine, so I'm fine. Not necessarily. ApoB can be high when LDL looks okay. My HDL is high, so I'm protected. Not automatically. Very high HDL doesn't cancel out a high ApoB. I'm low carb, so my ApoB can't be high. Some people see triglycerides plummet, which is great, while ApoB stays elevated. Patterns vary. Make sure you test, don't guess. And, I'll just take supplements instead of changing anything. Supplements can be adjuncts, but they should never be foundations. ApoB responds best to energy balance, carbohydrate quality, and proven therapies when needed. Here's your single card summary to screenshot. LDL-C equals cargo weight. ApoB equals number of ships. When they disagree, risk follows the ships. If this clarified a confusing topic, tap like so YouTube shows it to the people still flying blind on LDL alone. Subscribe for evidence-first episodes that turn biomarkers into simple action plans. Check the description for our book, Your Week-by-Week Blueprint, and a short list of tools that help you track the risk factors that actually move the needle. ApoB is not a trend, it's the sharper lens. Use it, lower it if needed, and let your arteries age more slowly. Thank you for watching. See you in the next video.